Hello, everyone. Right, I'm sure you're bored of us by now, but this is our last talk before we do our workshop and head to the airport. So we're going to talk about the danger triangle, the scary part. Today we're going to scare you a little bit. The danger triangle is called the danger triangle for several reasons. The first reason it's called the danger triangle is because the valves, the arteries, the vessels in the danger triangle are valveless. So any infection that happens within the danger triangle has the potential of traveling back to the brain. The second reason it's called the danger triangle, or we call it the danger triangle, because the arteries and the vessels in this area anastomose with the ophthalmic artery. The ophthalmic artery is the artery that supplies the eye. And anything, God forbid, happens to that would end up with necrosis. And that's why we call it the danger triangle. And we would see in most of our necrotic cases that happens in this area because, one, lack of anatomy knowledge, two, technique. So we've seen a lot of necrosis, and here's the thing. Very, 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 very rarely tissue goes back to what it was. The best case scenario, you're going to end up with fibrotic tissue or a scar. And there are several ways of treating it. But those are all areas, unfortunately, it could happen with beginners and it could happen with advanced injectors. So today we're going to talk about how to avoid it. And the reason, again, why it happens is because of all those naughty arteries that anastomose with the ophthalmic artery. And this is where the ophthalmic artery is. So what happens in such situations, and when we end up, God forbid, with a necrotic, you got two things that we need to worry about. Necrosis, and necrosis could happen due to intravascular injection or compression to the artery. The other serious complication that could happen is a bolus traveling inside, going all the way up and blocking this artery here, the ophthalmic artery. And this is how and the injection could happen anywhere in the in the danger triangle. It could happen up at the bridge of the nose, and it could happen sideways. Now, we all understand anatomy very well, and we all do know anatomy. We've studied it in the books. We've done cadaver. The one thing I could tell you is anatomy is not static. It's not always there. If you think that the facial artery diverts 1 centimeter away from the corner of the mouth to superior and inferior labial arteries, that's what we studied in the books, but that's not the case. That's not what always happens. Because that area is very, very, very vasculature. Dr. Francesco is going to tell you a little bit more about how diverted and how anatomy could change.
Well, this is just a representation. It's not a true thing. And one of the first things when you start after finish anatomy and going to dissection, there's no colors on the arteries, on the veins, on the nerves. You get lost on it. But the thing is, we tend to look at it as, oh, this is very dangerous because there's so many vessels there. Actually, gladly there's so many vessels there because you can overcome any blockage. So it's very rare to have a vascular complication in the lips, unless we have the unfortunate situation that you can find a terminal artery, and then you can have a problem there. The thing is, you see all these representations, and look, the lip has mucosa and muscle, mucosa and muscle, skin and muscle. There's no fat on the lips. So and sometimes you see people, oh, we have to inject subcutaneous or submucosal. There's not a real space between the mucosa and the muscle. You create it when you inject it. So you have to be careful with that. That's the main thing, is about pressure and quantity. And when you see textbooks like this picture, this is totally wrong. Just a schematic. Don't follow it. It's not true. And this is actually more close to truth. Possible variations of the lip arteries. All of those can happen. And the thing is, if you find yourself in a situation like this, anything that happens here is going to create an ischemia. But gladly, most commonly, are those up there, which are lot of anastomosis, lot of overrides that you can come out with. And also, you look, the artery is at different levels, subcutaneous, intramuscular, submucosa, and depends where you catch it, because it's not a straight, always the same plane. If you remember from the embryology, arteries and veins, they come before the muscle. The muscle develops around those, so the artery will be weaving through it. But it's one of the areas that you are more forgivable about complications, is the lips. That's why you do a lot of lips, and you can get away without any complications except swelling. Most of the problems with the lips is not vascular, is overcorrection, or wrongly done, or misplacement. So that's what I think. And how we do lips? Well, everybody has different ways of doing lips. This is a way of how most of the times I do my patients, by doing the injections with the needle in the mucosa, some small bolus somewhere, and the quantities, they vary. They don't need to be the same. But again, it depends on the structure. Well, the patient from the above picture, we might say she doesn't need anything. Well, but the patient wants a little bit more of plumpiness. It looks better in her face. She's from Jamaica, so it looks better on her face. If she was from UK, it doesn't look nice on her face. The patient below is Caucasian from Europe. It's just an enhancement. This is what we call a lip enhancement, not an augmentation, which is different. This is what we see sometimes Instagram. I don't have nothing against social media, don't get me wrong. I'm just not very active. But it looked like this. Oh, great. Now, this is just immediately after with a lot of cream on it and looks glossy and nice. But this is more like what you need to have, because these are results after a month. And you can have, in this case, a patient who has a mouth that is wider. You place the volume more medially, and it doesn't look so wide. A mouth that is narrow, you place it more laterally, it looks wider. So it's about getting the balance on those patients' faces. One thing I do like is having patients coming for lips with lipstick, because I can see what the patient wants. The way they use lipstick tells you which type of lips they're looking for, and gives you a good idea if it's achievable or not. Okay? Rami.
Yes. So there are two types of augmentation in my practice. You could either volumize or you could either contour. Those are both my patients, and they're ugly. It's very ugly. I don't like them. Because I don't think you could do one without the other. You have to combine. Now, in order to learn lips properly, what I did was I got a book which is called How to Draw the Face. And it's not a medical book. It's how artists draw the face. And I wanted to know the proportions and the relations of lips, how they relate it to other parts of the face. And what I've realized to start off with during my practice is the more character the lips has, the more harder it is. But you can't change the lips. You can't change the Cupid's bow. You can't do a V and change it into a U. You can't change a straight line. You've got a muscle, which is called the orbicularis oris. The orbicularis oris is a constrictor muscle. It's a very strong muscle. It will push the fillers back to its original shape. So when I first started practicing aesthetics, I used to give the middle third of the lips more than the outer third. So I would augment the middle third and I would augment the lateral third. Later on, I realized this is not the way forward. But here's the thing. I was in Monaco a couple of months ago, and I saw this book saying 52 ways to inject lips. So there are so many ways of injecting lips. There are so many different ways of augmenting lips. This is the way I do it. And relating back to that drawing book, what I realized is that the most volume in the lips should be in the middle third. The middle third is not lengthwise the middle third. So if the length of the lip is 6 centimeters, doesn't mean that 2 centimeters in the middle is the middle third. So the middle third should go with the nostril width, should go with medial canthal width. So this is the middle third of the lips that we use. And those are the lips, this is the area now that I only augment, and I don't augment anything else. And I make sure I go from outer skin into the lips, over the muscle, not too superficial. And that's how pretty much I do the lips. And later on, and after that, I do the contouring. But as you could see, the thicker the line is, the more material I place. So I place more material in the middle third than the outer third. So this is for the contouring, not the augmentation. And then finally, I draw those two fill trims in order to give that nice light and shadow in the middle. And it will all make sense once we do it to the patient. But then something came up they call the Russian lips. And the Russian lips basically is going very, very, very superficial, multiple injections along the lip in order to give it that nice plumpy look. So it's very subjective. You guys decide what you want to do. But always remember, when it comes to lips, you have, you inform your patients that there will be swelling, and there will be a lot of swelling. So this is the patient I saw 12 hours after injecting the lips. This is how swollen she is, and then this is how she looks after. So lips do swell. Make sure you inform your patient that's going to happen. From there, we're going to go back into our danger triangle and talk about non-surgical rhinoplasty. Non-surgical rhinoplasty has the advantage of surgical rhinoplasty with the downtime. It is reversible. We could change it. It doesn't require hospital admission. It's not as expensive, but it's technique sensitive. And it's very dangerous. The area is very sensitive as well. So if you're not very comfortable, make sure you don't inject, especially in your beginner days. The other thing you need to be very aware of is that if the patient had a surgical rhinoplasty, because yes, there's the safe area, which is the bridge of the nose, but whenever a surgeon goes in with that blade, remember that the anatomical landmark has changed and varied massively. So don't depend, so make sure you take the medical history very well. It lasts for quite a long time. It lasts for about 13 months because of the lack of muscle activity in that area. And usually, we place little drops and along the bridge of the nose, not the lateral side, because that's where the arteries and the vessels are. Remember, it is very vascular, and it is very technique sensitive. So we're going to show you now. But what you find is, in most of patients who require any alteration to their nose, what they usually want is the volume of the nose. They want a smaller nose. Remember, when you're placing filler, you're adding volume to the nose as a whole. So it's going to look bigger. But what you're trying to do, what we're doing is camouflaging. Camouflaging by hiding the hump and adding filler behind it and in front of it to make it very straight. That's as far as hyaluronic acid goes for non-surgical rhinoplasty. It's definitely worth there's a very good paper called, where's it not here? It's, sorry. Hunter and Miller, which would talk a lot about the lip technique.
Okay. Do something. We have to take it out, right? Rami, can you keep on talking?
Okay, right.
Fix this thing.
So, it depends on how you want to do it. You could do it with a cannula, or you could do it with a needle. If the hump is very big, you won't be able to go with a cannula, so you'll need to do it with a needle. Make sure you aspirate. If you are to use a cannula, make sure you use a big cannula. I'm not a big fan of popping local anesthesia or giving blocks, because anything that could go wrong, pain is going to be my first indication. Make sure you keep speaking to your patients. The first sign of any intravascular occlusion is pain, blurred vision. What you need to make sure even more is having hyaluronidase. So, we've done a lot of talks around the world, and what surprised me is that, yes, we do have hyaluronidase in the clinic. Not so many people know how to use hyaluronidase. A hyaluronidase for injectors is exactly like having oxygen or a defib in an emergency hospital department. You have to have it. This is the advantage of using hyaluronic acid fillers. The first thing when they talk about hyaluronic acid fillers is say that it is reversible. If you don't have hyaluronidase, then that's when it's going to, then that's negligence. And you need to understand how to use it. But more importantly, you need to train the whole team you have on what to do in an emergency situation, rather than running around asking your patients to get this, your others to get that. So it's all you need to do is, for example, in this case, just to add a little bit behind and in front of the hump. Those are Francesco's photos. And with the Asian nose, you need to be very careful because there's a certain limit you could give, not more. Because adding more might compress arteries and vessels in that area. Here's another beautiful case done by Francesco, 12 months after, where the filler is still. Is this hyaluronic? That's Elance, yeah?
That's Elance, yeah.
That's Elance. That's Elance placed. And here's another case as well.
This is more about the chin.
Elance as well. And it goes with the chin. So, to avoid necrosis in such areas and blindness, have a read through this paper. This is a really good paper, and it tells you step by step what to do in case of an emergency. Obviously, you need to stop immediately, place the patient in supine position, and refer the patient to the closest eye hospital. This is a routine that you need to do. Just like in BLS, you know exactly what to do if, God forbid, you've got a problem, a cardiac problem. So make sure everyone in your team knows. And I always get to ask the question, how much hyaluronidase do I need to place in the danger triangle? In case of compression, of worried about, if you're worried about vascular compression, in case you're worried about intravascular occlusion, all the hyaluronidase you have in your cupboard. Because the beauty of hyaluronidase, it passes through membranes. That's the worry of it. Now, yes, allergy has been reported, but you need to make, but the complication that could happen with intravascular occlusion in the danger triangle is way more serious. So make sure you know how to mix it. Hyaluronidase comes in 1,500 units. I think I've seen one that is already mixed. I'm not sure if it was in Pakistan, but usually they come in 1,500 units. You mix it with 10 mils of saline. Each mil will have 150 units. Now, those are the dosages of hyaluronidase placed when you want to dissolve on patients who are not satisfied with fillers. This is not the dosage of hyaluronidase when there's a worry about vascular occlusion. When there's a worry about vascular occlusion, you place all the hyaluronidase you have in the cupboard into the area. Now, this is how hyaluronidase work. So this is hyaluronic acid being placed. And this is something for you to think when you want to use hyaluronidase. You don't just inject it. After placing the hyaluronic acid, I'm placing now the hyaluronidase over it. It does dissolve rapidly. This is the beauty of it. But you can still see particles. So in order to have to dissolve it rapidly, what you need to do is not only inject hyaluronidase, but massage it to make sure you press, to make sure it goes through and you make sure you're getting rid of all those particles. And with a bit of massaging and injecting hyaluronidase, you get rid of the hyaluronic acid straight away. So it's all about knowing how to use hyaluronidase, not only having it in your clinic. And remember, not all noses are good for hyaluronic acid. Some noses will have to require surgery. This case was done by Dr. Francesco Di MELO. And so by adding filler in this case, you're just going to make that nose bigger. Therefore, some patients, remember how to say no and how to refer a patient to a surgeon to have a surgical rhinoplasty. Now we're going to do a couple of cases of lips, I think.
Yep.
In two different ways, and a non-surgical rhinoplasty as well. Thank you.
Well, why RAMI is going to the first case, I do the second, and then we flip a coin for the third. If you have questions,
Francesco.
that's a very good time.
Yes, yes, a lot of time.
I forgot to ask you, do you want to do the superficial way or do you want to do
Do it according to the lip.
Okay.
Well, I just have one comment regarding hyaluronidase. We got all these units, but depends how much was injected. So that is great if you have usually the amounts that were recommended to inject, but depends how much you're placing. So sometimes just need to repeat it. The thing is, we have control on the placement of the filler. We have no control on the result of hyaluronidase. And it's not just specific for the filler, it's specific for all hyaluronic acid. So it's not just what you place in that's going to go away. And remember that new hyaluronic acids, they were actually built to resist hyaluronidase. So when it comes to that idea about an antidote, well, it's not really an antidote.
And what about the residual loss of hyaluronic acid which is in the skin, not the one we had injected?
You do see patients that we have done hyaluronidase that somehow things change in the quality of the soft tissues. But
And
again, we do replace that quite fast.
yes.
So.
And what happens if we have dissolved hyaluronidase due to overfilled or nodules, when we can re-inject our hyaluron filler?
There's different papers on
enhance
that. Some people claim that after
both.
5-6 hours you can do it.
After 6-7 hours.
Some others wait until late to 2 or 3 days. Again, depends on the patient availability to come back to the clinic. I would prefer to wait for the swelling and everything to go down, things settle in, and then start again. I would
Okay.
prefer to do that, honestly.
Okay.
Unless there's an emergency for a wedding or something. But again, if there's a wedding, I think makeup artists can fix it much better than I can do. No
Yes,
swelling out
yes.
of makeup.
एक बात याद रखें कि hyaluronides is just like solocative, just like adrenaline in emergency. It is not only good for vascular accidents, but most of the times we have to correct the overdone fillers.
Oh, yeah, okay.
So the last slide which Dr. Rami had shown, कितने लोगों ने उसकी पिक्चर ली है? हाथ खड़ा करें. और क्या बाकी लोगों को वो सारी चीज़ ज़बानी याद है? अगर मैं किसी से पूछूं, किसी को याद हुई, किसी को नहीं याद हुई. इसलिए कि वो आप उसको बड़ा लाइट ले रहे हैं. और हालांकि ये एक चीज़ जो आपकी लाइफ सेव कर सकती है, that is hyaluronidase. Over-treated. If you have done over-treatment, this is the only thing which can help you out. ठीक है? और इसमें एक और भी बात याद रखें. Sometimes patients think that with the hyaluronidase, you had done lot of damage to my existing
Hyaluronic acid.
hyaluronic acid. So how you are going to deal with it?
No, I think it's more a matter of quantity and dosage and how you place it. Usually what I tell patients that need to do hyaluronidase for some reason, I tend to say, and hopefully keep on like this, that I do more hyaluronidase to patients I have not treated than the ones I treated before. So we're always guessing which filler was here, how much was placed, etc. But essentially what I found out, because we learned from our experiences, do a skin test first. Hyaluronidase is from ovine origin, so it can have some allergies. It's very rare, but it can have it. There's one hyaluronidase that's starting to be produced in the US, which is a recombinant one, but it's not available worldwide. So just be careful with that. And again, you can go progressively. Don't try to melt all the filler unless there's an emergency. But I always tell the patients, I can't control what I place. I cannot control what's going to come out. And because it depends on the level, depends how it was placed and which product was placed, essentially.
And what is, अब मैं वो question करने लगा हूँ कि 1 ml अगर आपने filler dissolve करना है, तो कितने units आपको चाहिए होंगे hyaluronidase के? अगर 1 ml hyaluronic acid you had injected, how many units of hyaluronidase is required? शाबाश, same, यानी कि कितना? 150 units. Do you agree?
I know, I don't agree that. Depends on the filler.
It depends upon the filler. But generally, so per ml, it is 150 units. It is 150 units. Okay. So this is the basic thing you have to remember. And मैंने आपसे देखा है कि जो इम्पोर्टेंट स्लाइड होती है उसकी कोई पिक्चर नहीं लेता और ये बहुत इम्पोर्टेंट स्टेप है, इसको अपने पास हमेशा सेव रखिए, ठीक है? क्योंकि ये लिटरेचर को आप रिव्यू करने जाएंगे ना, जस्ट टू गेट वन स्लाइड you have, it will take at least 2 hours to get this.
And the other thing is, how I see the early days is something I buy, I have in my cabinet, and I expect it expires without being used. That's how I look to hyaluronic days.
Yes. It should not be used, but it should be there.
Well, Rami as a patient, they're ready.
Yes. My friend, are you ready?
Born ready. Can we
can use the camera?
Use the camera,
and
please.
take this nose out of the way.
Brilliant. Right. So going back to what I'm talking, over here we're going to treat those aging lips. So I'm going to start off by.
अब मैं दोबारा आपसे क्वेश्चन करूंगा और
drawing the middle third, and the middle
otherwise जुर्माने के लिए रेडी रहना.
And the middle third is the only place so this is the area I'm going to be working on. I'm going to avoid giving the lateral third. Because what I find is, because of the orbicularis oris muscle, which is a constrictor, again, just like the cheeks, we can't assess the patient only when the patient is still. We need to assess the patient when the patient is smiling and speaking. And what I found was, if I place hyaluronic acid to the lateral thirds, it will look absolutely beautiful when the patient is still. But the minute the patient is going to smile, we're going to have that tube look, that which I don't like. And lately I've been doing a lot of removal of fillers from the lips or fibrotic tissue. So I'm going to start off, I'm going to use a needle, and I'm going to use, in her case, because I want more volume, I'm going to use define, not precise. Can I have a needle, please?
Rami, do you always mark the lips?
Not really. Now I know that I'm just going to stick to the middle, so I don't mark them. But for teaching purposes,
yeah, that's good, yeah.
This is the area that I'm going to stick to.
The other thing is sometimes I see people doing, they plan the lips always in the same way, independent of the lips. And one of the things I really notice is when they want to try to recreate the philtrum. Some lips have no philtrum at all, never had. And the moment you create one, it's a different person.
It's a different.
So it's not one size fits all. Again, you have to follow what's in there and to balance it.
So what I'm going to do, I'm going to go from outside the skin, and my filler is going to look exactly like that inside. I'm going to go in and in and in. So I'm going to give like 3 lines as I showed earlier. So this is how it's going to look from the inside. I'm not going to give it too superficial, and I'm going to give 1, 2, 3. I'm going to go do the exact same thing on the other side. And remember when to stop pushing your finger on the plunger. It's where the tip meets the vermilion border level. We don't give more than that. And then I'm going to give on the side as well. And then I'm going to do the exact same thing I did in the middle. I'm going to hold the lips up. I'm going to go 1, 2, 3. So as far as augmentation, I'm happy with the augmentation I have so far. Now I'm going to do the exact same thing with the lower.
How much you have injected up till now?
0.3.
0.3?
Yeah.
Good job. What a nice change with 0.3.
It's all about placing it over the muscle, not too superficial, but not too deep. Same thing.
And when you say superficial or too deep, is in the muscle.
Just over the muscle. I try placing it.
Can you find a place over the muscle?
No, I try.
I can't.
Mm-hmm. Now we've done that, I'm going to move to my look.
I think one of the good things about MaiLi and Define is the lifting capacity that it gives. You don't need a lot, and it's very, very soft.
I'll start giving the vermilion border, just a bit of definition. Now I'm going to give less here, very little, I hold the needle between my fingers. I'm going to start giving more.
So what will happen if someone has injected too superficially
Sorry?
with the MELI?
Oh, it's not going to happen anything. I think it might have a bit of bumpiness. But because with the massage, it's quite easier to, there's a very low G prime.
Okay.
It's very easy to spread.
But again, when you want to massage it, make sure you don't massage it strongly because you're going to end up causing, the lips are very vascular, and you might end up with a hematoma and bruising.
Honestly, I saw that usually my hematomas and bruising is from the needle, not from my fingers.
I've had, in my case, no, I've had them with
Disagreed.
Sorry?
Disagreed.
Yeah.
I'm going to give now my filtrums.
She does need, she had a filtrum before?
A teeny weeny bit, I could see that here. Does anyone not have a filtrum?
Sometimes I agree. If patient has no filtrum, no cupid bow, and you are injecting it first time, an immediate response after seeing in the mirror, it's...
And if you go over time and if you look for the past, well, this has got started in pictures and magazines and movies. Well, that's really nice.
Very nice.
Yep. And then finally, sometimes what I do is just to give it a little bit of a push, thank you, and just give a little bit where the filtrum starts, and in the middle I give 3 little towers of hyaluronic acid inside the lips to give it that nice push or pout. Can I have some Vaseline?
Rami, if you have a leftover, what do you do with it?
Throw it away.
Throw away, yeah.
Huh? You will throw away? In Pakistan? No way.
Less
no
is
way.
more.
Maybe.
You know what
I leave it for touch-ups 3 or 4 days after.
You know what happens with the leftovers? You're going to place it in somewhere that was not planned, and that is going to give you problems.
Yes.
And
That
usually, it's the last patient of the day.
Yeah.
You're tired, and it's before a weekend, and you're just going to see them on Monday, and everybody will be...
Yeah.
So I just keep it out.
Always, there's a question. How many days you can keep a filler when you have opened the syringe?
Right, so there are 2 ways to answer this question. One, you have the health authority regulatory laws. Because, for example, in Saudi Arabia, if they come into your clinic and they find an open syringe for more than 24 hours, you get fined. In Dubai, it's 1 week, isn't it?
It's a gray area.
No, they defined it lately.
Yeah,
I think
but
so. Yeah. 30 days for hyaluronic acid to stay open in the fridge.
Okay.
Okay.
It means it's safe if we can
Now,
keep it for 1 week for touch-up.
Yeah, so this is the answer for as far as health authority. I would stick to that. I would usually keep it only for 5 days. But that's when I give, if a patient needed top-ups. After that, I throw it away because you don't want the patient to come in every 3 months asking for a top-up and adding more to it.
And
now, let's not forget that this is open. When we opened, it's from sterile, it became non-sterile, so that's a source of infection as well. So you want to avoid that opening and closing multiple times.
And you have to throw up, have to discard part of it because...
yeah.
Honestly, I think if you have a leftover, depends on the amount. I don't think it's something for us to keep it for a long time. But again, depends on your practice. I will not advise to keep it, honestly.
Yes, I also agree. Because if you keep a very tiny amount of the patient, of the filler, patient will keep on calling, Doctor, आपके पास मेरा filler पड़ा है, संभाल के रखना.
So,
Doctor, मेरा filler संभाल के रखना, किसी और को ना लगा देना. Always throw away the filler syringe in front of the patient. Okay?
second lip.
Second pair of lips.
Second patient.
Okay.
So, Dr. Rami,
Yes.
what's your opinion about injecting the lip with the cannula?
It's more painful. I don't have much experience in it, so therefore I don't know. I find that using a needle is more precise, especially in areas where every little bit matters. So in all honesty, I'm not the right person to speak about cannulas because I don't use it in my practice. I tried it a couple of times. It was nice, but the patient felt a lot of pain. Therefore, I avoided it, and I'm not a big fan of blocking the lips either.
Yeah.
Because, God forbid, I'm in the wrong place, the pain is an indication.
It's an indication.
Yeah.
And among these products of MaiLi, which one is your favorite?
Depends on the indication.
No, for the lips.
Depends on the lips. For her, in her case, she had pretty much 0 lips.
Okay.
So I used Define.
Define.
If for a 20, 30-year-old girl who's coming for lips as a fashion statement, I would use Precise.
Precise. So what is the basic difference between these two products?
The viscosity of them.
Viscosity.
The Precise is the most flowy one. Then comes the Define, then comes the Volume, and then the Extreme is the most viscous and hard.
Most viscous. What is your opinion that sometimes in the fashion magazines you will see the models with banana roll lips and they are not moving. So what do you say about that?
If you don't have it,
I find that beauty is very subjective.
Alcohol is fine.
Yes, that's true.
I learned that. I remember I was in a fashion show once, and there was a designer who came in Italy, and I was looking at the catwalk. And I was looking at them, and I'm thinking, who would wear that? It was sold out for a lot of money. So obviously, there's a market for everyone. So it depends. It's very subjective.
But what is your preference?
I don't like it. I would prefer not doing it because my patients are my walking marketing.
Yes.
So I would prefer not to do something that looks very, very fake.
Very, very fake.
Yeah.
And if I inject high viscosity filler in the lip,
it's going to be very hard and it won't feel nice.
Yes. So remember one thing. Shh. जब से लड़कियां डरमा में ज़्यादा हुई हैं ना, मैं कहता हूँ कि हाल में 1 मिनट सन्नाटा नहीं होता. Never. कह के याद कराना पड़ता है. Pin drop silence. अच्छा, let's start.
Let's start with the lips.
Okay. We have a different lips now. And we had a brief talk to see which type of lips that I would like to have. And she gave me carte blanche, which means I'm in trouble. Because I can do whatever I want, and I don't want to do whatever I want to do whatever she needs. So can you just look a little bit to the camera, like this? You can see the lips are quite thin. There's a very little filter, and the upper lip is very short. When you have an upper short lip, is the white lip, we have to be very careful what we do, because if we invert it too much, it will look like it's touching the nose, and it doesn't invert as much, it can actually project it, and it looks very, very strange and stiff. The mouth is wider, and I think she can definitely benefit more from eversion than anything else. So there's different ways of getting it.
Someone yesterday asked how to invert the lip.
Okay.
Yes, please.
So if you can look
I remember.
there. The thing is, can you open your mouth a little bit?
Surgically.
So we have two options here when you do lips. You can go into the mucosa and do it from the mucosa parallel to the lip contour, which is something I think is easier for my side, because that just is like painting by numbers, just follow the contour, what's in there, and just place it. You can do like Rami showed it, going to more vertical. And you can do something, which is something I really like. It's a very, very old technique. It's going to the back of the lip to bring it out. And when I got small lips and thin lips, when I cannot have much room to get a lot of volume, I do like to start with that. And then I just balance it. But the lower lip needs quite a good work, because the mouth is wide, nice support on the sides, and I need also to bring it outwards to balance with the upper lip. So let's do it. Let's see if I can get it right without putting anything to bleed. Okay, can you open your mouth a little bit? So I'm going to get through the skin. 1, 2, 3. You see in the back, the tip of the needle?
Yeah.
I am on the mucosa side of the orbicularis. And I'm going to place a small bolus right under the cupid arch. Let me get the, so you can see the scale there.
It's important that you have eye constantly on the
There we go.
scale.
And then I just, without taking the needle out, I'm just going to make it down to the mid part. And again, you can see the needle is in the back there. You can see me pushing it. My finger is just there to control the depth. And I put another small bolus like 0.05. I'm not pushing the needle out. I'm injecting a bolus where I have the tip, okay? And I take it out.
This is nice.
And you can see
Yeah.
how it is diverted with 0.1.
Just 0.1?
0.1.
Oh. What
Just
a
by
nice
pushing
theory.
it under the muscle, placing it under the muscle.
So what is happening is the bolus is on the mucosa side of the muscle and just pushes it outwards. And do the same thing on this side. That's it.
So your entry point is quite far away.
Yes, and I just,
Yeah.
because I want to go away, because if I go closer, actually I'm closer to the artery. So I'm just going in the back of it.
Okay.
Again, under the cupid arch. 0.05. Directed downwards, 0.05. And then I just massage it to make sure it's even. Okay? And you can see it's
Very nice.
reverted.
Very, very,
Very
nice.
natural.
Guys, this is not circus. It's just using the anatomy. You know, it's very simple. Then I need support on the lateral part. And if I go closer to the vermilion to the white roll or the skin mucosa transition, I'm going to get projection and contouring. It's a very young face, young lips. They don't need contouring. The contouring is there. I just need to go a little bit under, just to highlight and add the volume. Small, small prick. And just 2 lines here. And another 2 lines. Okay, again, 0.1.
0.1.
So you're adding support under the muscle, and then you're adding volume over the muscle.
Yes.
That's pretty much, yeah.
Now
Okay,
you
the same principle, go from the depth to the
Yeah.
surface.
So I think that you can see clear-cut difference.
The same thing on this side. And you massage it, and another just more medially. Because this side is a bit smaller than the other, I need a tiny bit more. That's it,
That's it. So total 0.4 ml.
for the upper lip. Okay, now it's to balance the lower lip, and the lower lip is going to need more volume.
Yeah.
So, very classic way. Start more lateral on the lower lip because you can have more width. Just 2 lines, 1, 2, 3. Two vectors. Then I go more medially, and I'm going to do 3. One at the junction of the dry mucosa with the wet mucosa. The other one in the middle of the dry mucosa. The third one closer to the skin mucosa junction. And that's it. Okay? The same thing on the other side. I'll try not to be in front of you. Again, dry mucosa, junctions of both, and on the anterior part. Fine now, precise. Needle.
It's very nice.
Very nice.
I just want to add something. I
Yes.
want to use a bit of, because it's a workshop, right? So I'm going to use a bit of precise just to define the eversion on the lower lip closer to the contour, because the upper lip has a nice shape, the lower lip needs a little bit of shape.
It's very
That's all.
natural. Very, very natural. There's one question.
Yes.
Sometimes people, they inject 2 bolus just below the, from the lower side of the lip to the upper side.
Yes.
One here and one here to create the tubercle.
Yes.
So,
You can come from that.
okay.
I prefer to go from the mucosa. That's what I'm going to
From
do
the,
now.
okay.
Okay, so I just want to highlight a little bit the contour here. This is precise.
Previously, you were injecting precise or not?
No, define.
Define.
I was using define. Look, precise, just give a bit more of contouring. Like, look, just gets a bit more of definition there. Creates like a ridge. But without being a very hard ridge, which is what we don't want. The same thing here. To get those tubercles, you can come from there, you can come from out. It's up to you.
So, we like to see your technique.
Well, I just do this.
Excellent. Point 1?
Point less, a bit less than that. And now I need to do a little bit in the middle to invert it. And instead of going there, I just go a bit more close to the edge. And a bit more superficial, not so deep in the muscle. That's it.
That's it.
And just massage. How are you? Bearable?
Don't be so harsh as Rami said. You can create a bruise.
Oh no, I do.
Hematoma.
I'm more aggressive with my fingers than with the needle. Okay.
After how many days you recommend touch-up for the lips?
Can you look there?
Very natural. What a
many-
great job.
That's it. Brilliant. Let me give you a mirror.
Do we have a nose, or do we have time for a nose, or no? No?
You like it? We have to talk. Or I have to call for yellowy days now. Let's have a sit. Let's have a sit.
Very nice.
Okay.
Very nice.
So what I do tell the patients after this, ice. Ice packs and avoid hot drinks for the next 2-3 hours. And please don't smoke.
Don't smoke.
You happy?
Thank you.
Just you might have a little bit of it. Yes. No, this swelling that goes away quite quickly.
How much time will it take for the non-surgical rhinoplasty?
You do. You want to do it?
I don't mind. But
No, it's fine. Yes. Tomorrow morning will be a bit swollen. 10 minutes. The question is when the swelling is going. So tomorrow morning, the first 2 days, always a bit of swelling. After the second day, you should not have much more swelling. But just maybe in the morning, then.
I'll do it.
Define.
Define. Yes. This is what we have, right?
One's enough.
Needle.
Needle. So lips are actually a very forgiving structure. Let me go there. Thank you. Just more a matter of look to the patient, debate with the patient, and be conservative with the volume.
Right. So
That's it.
please put the camera here.
So our next area is the nose. And
As you are. For me? Or what is it? Panadol. Oh, did I ask for Panadol?
Rami, are you ready?
No? Right, okay. So, zoom, let me see the camera.
Can we go into this camera, please? So if you are wondering which is the best filler in the world, cake.
Yes.
The best fill in the world, but just filling in the wrong places. That's the problem.
Okay. What's your name? Shazia? Dr. Shahista. Okay. So Dr. Shahista wants her nose to be done with fillers. So here's what we're going to do. If you look at her to the front, we do have a little bit of deviation. Deviation means I need to correct the deviation by filling this side, which is a no-go zone. We should never go here. What we're going to do is try and hide this hump here by adding fillers in this area. So what I'm going to do, this is the area I start off by marking where my filler is going to be placed. Once we lift this area up,